Welcome back to the deep dive. Today we are taking a voyage deep into the neck.
Not in a scary way, I hope.
No, not in a vampire novel kind of way.
Yeah.
I mean, we're exploring the incredibly complex, really high-stakes machinery that's just sitting right under your chin.
It's a fascinating intersection, isn't it? You have air passages, food passages, nerves,
Hmm.
all packed into this tiny, very mobile space.
It's like Grand Central Station for your body. And honestly, most of us don't think about it until it, stops working, right?
Well, that's the mission today.
Yeah.
Our source material is a masterclass on the clinical examination of the larynx and hypopharynx. We're not just memorizing parts.
No, we're learning to read the body's distress signals.
Exactly. We're going to uncover some of the hidden geography of the throat. Because, and this is what's so interesting, there are parts of your own anatomy that are almost designed to be invisible.
Even to a doctor. And the source material for this is fantastic. It covers everything from like using these tiny mirrors to literally see around corners in your
A
throat.
classic technique.
All the way to physical signs you can actually feel with your fingers. It's real detective work.
It absolutely is.
Hmm.
And like any good detective, you have to know the territory first.
Hmm.
If you don't know what normal looks and feels like, you have zero chance of spotting the abnormal.
Okay, so let's set the scene. We're dealing with two main players here. The larynx and the hypopharynx. I think most people use those terms interchangeably, right?
They do, and you can see why. They're neighbors, very close neighbors. But they are distinct. The larynx is what we all call the voice box.
The airway.
It's the airway. Its job is to protect your lungs and, of course, produce sound. The hypopharynx, on the other hand, is part of the food passage. It sits just behind and to the side of the larynx.
So if I'm making a mental map, larynx is air and voice, hypopharynx is food and swallowing.
That's the fundamental divide, yes.
Yeah.
And to get our bearings, the source material breaks the whole pharynx, the throat down into 3 levels. Think of it like a 3-story building.
I like that. Okay, so walk us through the floors.
The top floor is the nasopharynx. It's up behind the nose. We're not spending much time up there today.
Okay.
The middle floor is the oropharynx. And then the basement, the lowest level, is the laryngopharynx, which is another name for the hypopharynx.
I want to pause on that middle floor for a second, the oropharynx, because the source pointed something out about the tongue that I found genuinely surprising. I just assumed my tongue was, well, in my mouth.
The very common assumption.
Mhm.
But anatomically, your tongue is divided territory. The front 2/3, the part you can stick out,
The say ah part.
exactly, that part belongs to the oral cavity. But the back 1/3 is actually part of the oropharynx.
So it's in a totally different anatomical zone.
Correct. There's a V-shaped line of taste buds, the circumvallate papillae, that marks the border. And once you cross that line, you're technically in the throat, not the mouth.
And that matters because why?
Different nerve supply, different lymphatic drainage. A problem at the tip of your tongue is a mouth issue. A problem at the very back is a throat issue. Got it. Okay, so that leads us down to the basement, the hypopharynx. This is the area surrounding the voice box.
Yes, running from the hyoid bone down to the cricoid cartilage. It's the chute where food slides down on its way to the esophagus.
And this is where knowing what's normal becomes so critical. I mean, the source talks about spotting a phonatory gap
Right, a great example, a phonatory gap.
Hmm.
Well, when you speak, your vocal cords are supposed to come together and close completely.
to vibrate properly.
Yes, but if there's a gap, if they don't quite meet, air leaks through.
And your voice sounds breathy.
Breathy, weak, exactly. And if you don't know they're supposed to meet perfectly, you might miss that subtle sign. Or you might miss what's causing it, like a small growth that's physically blocking them from closing.
Speaking of things growing in hidden places, let's talk about the hidden pockets. The source spends a lot of time on something called the piriform sinus.
Ah, the piriform sinus. It's a fascinating and, frankly, dangerous piece of anatomy.
It sounds a bit like a smuggler's cove in the throat. That's a fantastic way to put it. It is a smuggler's cove. It's part of the hypopharynx, and it's shaped like an inverted pyramid.
So, upside down, wide at the top, pointy at the bottom.
Precisely. And it's tucked away. The outside wall is the thyroid cartilage, and the inside wall is made up of other laryngeal structures. It's literally a channel for food to slide down around the entrance to the airway.
But because it's a pocket, things can get stuck.
They absolutely can. It's a very, very common place for foreign bodies to get lodged. If you ever swallow a fish bone, there's a good chance that's where it ends up.
It's a natural trap. But the source is less worried about fish bones and more worried about cancer. Why is this spot so bad?
It's what we call the hidden apex problem. Because the bottom tip of that pyramid, the apex, is deep and very hard to see. Malignancies can start growing there and cause no symptoms at all.
They're not blocking anything yet.
Not at first. They just sit in that pocket expanding silently. By the time a person actually feels something is wrong.
The tumor can be quite large.
Exactly. They often present late for this very reason. The anatomy itself hides the disease.
That's terrifying. It's like a design flaw.
It's a double-edged sword. And there's more. The superior laryngeal nerve runs right through the wall of that sinus, so clinicians can actually use that spot to do a nerve block for procedures.
So, high-value real estate. Bones, nerves, tumors. And this brings us to a diagnostic clue I found fascinating. Jackson's sign.
Yes, a classic clinical sign. Jackson's sign is simply the pooling of saliva in the piriform fossa, or sinus.
Okay, unpack that. Why would saliva just pool? Shouldn't it just drain?
It should. Normally we swallow, gravity works, and it all goes down into the esophagus. But if a doctor looks in there with a scope and sees a little puddle of saliva that isn't clearing,
It means the drain is blocked somewhere downstream.
you've got it. It implies an obstruction further down, maybe in the esophagus or the postcricoid region. You're not seeing the tumor itself, you're seeing the traffic jam it's causing. It's an indirect clue.
That's brilliant. It's pure detective work. You see the consequence, not the cause.
And that's the art of it.
Yeah.
Now moving from looking to feeling.
Right, the physical exam. Then this term came up, laryngeal crepitus.
Yes,
Crepitus sounds like something breaking, like a creaky knee. But here, it's a good thing.
it's a very good thing. Laryngeal crepitus is a tactile sensation. When a doctor holds your larynx, your voice box, and gently moves it side to side,
You feel a click.
you feel a grating or a clicking sensation. It's not painful. That click is the sound and the feeling of the cricoid cartilage rubbing directly against the cervical vertebrae, your spine behind it.
Wait, you're literally rubbing the voice box against the backbone.
Yes, and the fact that you can feel that click means there's nothing in between them. The space is clear.
Okay, so a clicking voice box is a happy voice box.
In this context, yes. It means the postcricoid space is empty, just like it should be.
Which brings us to the opposite, Baca's sign.
Baca's sign is the absence of that crepitus. As you go to move the larynx, and instead of a nice crisp click, it feels mushy, damp.
Looks like there's a pillow in there.
That's the perfect analogy. Something is cushioning the space, and that is a massive red flag. It means something has filled that space between the larynx and the spine.
And that something could be.
A postcricoid malignancy is the big worry. A tumor. But it could also be scar tissue from radiation or bad inflammation, even a foreign body. But whatever it is, it's lifting the larynx away from the spine and making that click disappear.
Amazing how much you can learn just from a simple wiggle of the neck.
It's the foundation of clinical examination. It's still incredibly valid today.
So now we have to talk about the classic say ah moment. The source goes into detail on indirect laryngoscopy, or IDL.
This is the old school technique. Before we had fancy fiber optic cameras, this is how you looked at the vocal cords, with a small angled mirror on a stick.
It seems so low tech, just a mirror and a light.
Low tech, but highly effective in skilled hands. You hold the patient's tongue, place the warmed mirror against their soft palate, and angle the light just right. You can see the base of the tongue, the epiglottis, the vocal cords.
But it's all backwards, right, in the reflection.
It is. Left is right, front is back. The doctor has to mentally flip the image while they're working. It takes a lot of practice.
And the source says it's not a static exam. You don't just take a snapshot.
No, it has to be a dynamic assessment. You need to see the machinery in motion.
Which is why they have you say ah and e. It's not just to get your tongue out of the way.
Not at all. When you say E, your vocal cords come together, they adduct. We can watch to see if they're moving symmetrically, if one is sluggish or paralyzed.
And then the deep breath.
The deep breath makes them fly open, abduct, to let air in. If one cord stays put while the other moves, you know you have a problem. You're testing the motor function in real time.
But even with all this, the source gives a big warning. You still can't see everything.
No tool is perfect. And the mirror exam, IDL, has some significant blind spots.
Okay, where can things hide from the mirror?
Well, think of the angle. You're looking down from above, so you can't see the underside of the epiglottis, the part facing the larynx.
It's in its own shadow.
Exactly. You also can't get a great view of the anterior commissure, the very front V point where the cords meet. And you can't see inside the ventricles.
What are the ventricles?
They're little pockets between the true vocal cords and the false cords just above them. You can't see inside that little horizontal slit with a mirror from above.
And I'm guessing the bottom of the piriform sinus.
It got it. The apex of that inverted pyramid.
Yeah.
It remains a notorious blind spot for the mirror exam. That danger zone stays hidden.
So you can look right down someone's throat and still miss a tumor if it's hiding in one of these pockets.
Precisely. Which is why you have to trust the patient's symptoms. If they persist, but the mirror exam is normal, you don't stop. You dig deeper.
Let's talk about the symptoms then. How do these problems actually feel? The source makes a nice distinction between laryngeal and hypopharyngeal symptoms.
Yes, and that distinction can really guide the clinician. If the problem is in the larynx, the airway, the voice box, the symptoms are going to be about sound and breathing.
Hoarseness.
Hoarseness is the #1 symptom. Voice changes, maybe a cough if there's irritation. The patient sounds different.
Whereas if the problem is in the hypopharynx,
That's the food passage. So the symptoms are about swallowing. Dysphagia, which is trouble swallowing, or odonophagia, painful swallowing.
what about that feeling of a lump in your throat?
The globus sensation, yes. The source notes that while that can be stress-related, it's very often linked to acid reflux.
Wait, heartburn causes a lump?
It can. Stomach acid comes up and spills over into the hypopharynx, irritating the tissues. The patient feels like something is stuck there, but it's really just inflammation from the acid.
So if you're hoarse, check the voice box.
Yeah.
If you can't swallow, check the food chute.
That's the general rule of thumb. It's a great starting point.
This has been amazing. We've mapped the throat, we've explored that hidden pyramid of the piriform sinus, and we learned why a clicking neck is actually a good thing.
It just shows you how crowded and vital that small space is. And the clinical exam is all about finding clues in that hidden space, whether it's pooling saliva-Jackson sign or listening for crepitus.
It makes you appreciate how much is going on that we take for granted. I mean, we're using our voices and swallowing constantly right now without a thought.
And the machinery that allows it is totally invisible to us.
That's really what sticks with me, that we have these blind spots built right into us. Even with modern medicine, there are corners of our own biology that are designed to stay dark.
It does raise a final kind of provocative thought, doesn't it? How much of our own biology is designed this way to be hidden? I mean, all this complexity, the folds and pockets, that's what gives us the ability to sing or swallow a huge meal.
So the complexity is the feature.
It is.
Yeah.
But that very same complexity creates the perfect hiding spots for disease. The intricate design is both our superpower and our vulnerability.
Something to think about. Thanks for listening to this deep dive. We'll see you next time.